I want to talk today about a common medication issue we encounter in our advanced heart failure patients. This is a case illustration. A 60-year-old man with ischemic cardiomyopathy, severe heart failure, and EF of 20% is started on furosemide 40 mg twice a day, lisinopril 5, and carvedilol 3.125. A week later, he complains of mild exertional dyspnea and mild dizziness. JVP is 11 cm with no peripheral edema. Blood pressure is 92/67. His creatinine rises from a baseline of 1.3 to 1.8 mg per deciliter. BUN rises from 24 to 34. What is the next step in light of this blood pressure and this creatinine rise and some of the symptoms and exam? A. Discontinue lisinopril. B. Discontinue carvedilol. C. Reduce the dose of furosemide to 40 and keep the rest. D. Reduce furosemide and discontinue lisinopril. E. Continue the same regimen. Or F. Reduce furosemide, hold lisinopril for a few days, then restart lisinopril. The answer here is E, and I will dissect that. So this case illustrates two issues we encounter. One, how to handle blood pressure before and after ACE inhibitor, ARNI, beta blocker initiation, and even aldosterone antagonists and SGLT2 inhibitors. And number two, how to handle creatinine rise with those medications. So the first issue, how to handle blood pressure before and after medication initiation. One, before you initiate ACE inhibitor and beta blocker, the blood pressure contraindication is symptomatic hypotension less than 100 to 110, meaning less than 100 to 110 with dizziness, weakness, or oliguria, or asymptomatic hypotension less than 90 millimeter of mercury. And for ARNI specifically, asymptomatic hypotension less than 100 millimeter of mercury. For ARNI, this is based on Paradigm HF inclusion criteria, ESC guidelines, and the LIFE trial of advanced heart failure, which showed a hazard concern with ARNI in advanced heart failure with a baseline SBP of around 100 to 110. Now, number two, after initiation of ACE inhibitor and beta blocker, asymptomatic hypotension less than 90 millimeter of mercury is actually accepted, unlike asymptomatic hypotension before drug initiation, which contraindicates those medications. Asymptomatic hypotension under therapy does not dictate a drug interruption. Even symptomatic hypotension, that is with mild symptoms after drug initiation with mild dizziness or weakness, does not dictate a drug interruption or reduction because it often improves within a few days of therapy, and it does not warrant cessation of therapy unless severe and persistent. Keep this therapy unchanged as long as the patient can stand, think, and urinate, meaning the symptoms are not severe. And try to stop nitrates or reduce diuretics, especially in the absence of congestion. Hypotension of 80 to 90 millimeter of mercury in systolic heart failure, particularly under therapy, may be well tolerated as it helps unload the LV. And in fact, based on all major trials of all those major therapies, blood pressure often rises with time because these medications improve LV function and cardiac output over time. And that's why that dizziness or weakness tends to be transient. And if it's not severe, you can stand, think, and urinate. Try to keep it. Hopefully, it will get better. Only if it is severe or significant and persistent, you need to interrupt or reduce the medication. And here is the data. This is regarding baseline blood pressure. A sub-study of the Copernicus trial of carvedilol in advanced heart failure with severe symptoms at rest or minimal exertion showed that heart failure with chronic SBP less than 90 millimeter of mercury derives the same relative benefit and more absolute benefit compared to patients with higher SBP despite the lower tolerated carvedilol doses. This is because the sickest patients with the lower SBP derive the most benefit despite the lower doses. This is generally the case. The sickest patients derive the most absolute benefit from established therapy, even if you can only use lower doses. Patients with the lowest SBP are at highest risk of an event. They get the greatest absolute benefit from treatment with carvedilol and other therapies. In this trial, they did not have a significant drop of SBP with carvedilol. In fact, blood pressure increased over time above baseline with therapy as a result of the increased cardiac output. And this is a graph from this trial. You can see that patients with hypotension who received carvedilol had a progressive rise of blood pressure over time. They did not experience hypotension. In fact, their pressure was higher over time than placebo. Patients with higher blood pressure did experience a blood pressure drop with carvedilol, which is expected, but not patients with hypotension. The sickest one experienced a rise of blood pressure with carvedilol. And patients with the lowest blood pressure actually experienced the most dramatic improvement of symptoms with carvedilol compared to placebo, as well as the most reduction in cardiac events with carvedilol. A similar phenomena was seen with condesartan in CHARM, valsartan in VALHEFT, ARNI in PARADIGM, and hydralazine nitrate in AHEFT. In fact, those drugs reduce blood pressure and hypertension, but may increase blood pressure in patients with severe heart failure and low blood pressure after a few days of hazard. And this is a slide from AHEFT trial of isosorbide hydralazine. Isosorbide hydralazine effect on mortality was no different in patients with a baseline SBP below or above the median. And in fact, therapy was associated with a more dramatic relative and absolute reduction of mortality in patients with a lower systolic blood pressure than those with the higher one. And you can see here that patients with a baseline blood pressure less than 100 experienced a progressive increase of blood pressure with therapy. Similar findings were seen in CHARM study in patients with a baseline blood pressure less than 100. Blood pressure on average increased with condesartan in the lowest blood pressure category. Now, after showing the data regarding blood pressure at baseline, here is the data regarding blood pressure during treatment. Hypotension during treatment, whether symptomatic or not, is associated with higher mortality, similarly to low blood pressure at baseline, but it's also associated with more dramatic absolute and relative benefit from heart failure therapies, even at lower doses, such as ACE inhibitor or even more so ARNI, as this hypotension reflects sicker heart failure. These drugs are continued if symptoms are mild or improving with time, or interrupted and restarted at lower dose only if symptoms are intolerable. Eventually, they can be continued in over 80% of such patients who experience hypotension. So don't give up in patients who experience asymptomatic or mildly moderately symptomatic hypotension. Even ARNI, Entresto, which is avoided if baseline SBP is less than 100, may be continued if SBP drops to less than 100 during treatment without severe symptoms. In fact, in this post-hoc analysis of the PARADIGM HF trial of ARNI versus ACE inhibitor, patients who experienced hypotension with therapy derived the largest benefit from ARNI compared to ACE inhibitor therapy. But again, avoid starting it if the baseline blood pressure is low, less than 100, as suggested by PARADIGM HF and the LIFE trial. But if they experience hypotension with therapy without severe symptoms, try to keep ARNI. They would derive a more dramatic benefit than switching to ACE inhibitor or worse, interrupting therapy. And all this benefit described is under continued therapy despite hypotension. Now moving on to the second issue, how to handle creatinine rise after initiation of ACE inhibitor or ARNI. In advanced heart failure, the worsening of renal function may be related to the low blood pressure and low kidney perfusion state that gets aggravated by initiating ACE inhibitor, as ACE inhibitor impair renal autoregulation, which is already maximized, particularly that filtration fraction is already maximized. It can reach from a baseline of 20% to over 50% via efferent constriction and afferent dilatation. So autoregulation is already maximized and exhausted. You add ACE inhibitor, that autoregulation get overwhelmed and the GFR drops. Yet, despite that, a rise in creatinine of over 25% or over 0.3 mg per deciliter, or even a rise in creatinine over 50% early after initiating ACE inhibitor is not associated with a loss of benefit while you continue ACE inhibitor despite this rise. And in fact, renal function largely recovers on follow-up. In fact, in two post-hoc studies from the SOLVED trial and from the VALHEF trial, patients with early worsening of renal function, meaning creatinine rise more than 25% or even more than 50% under ACE or ARB therapy, those patients with early worsening of renal function appear to derive the largest relative and absolute benefit from continued ACE inhibitor therapy. Why? Because those who have worsening of renal function are those with the most severe heart failure and the most severe basal renal hypoperfusion. Those are the patients with the most exhausted autoregulation. ACE inhibitor breaks that autoregulation, but at the same time, ACE inhibitor improves outcome in those sickest patients with the most severe heart failure. And that's why eventually their mortality does improve the most with therapy. And renal function largely recovers on follow-up under continued ACE inhibitor or ARNI therapy, mainly because those therapy improve heart failure and therefore they increase the inflow perfusion pressure of the kidneys and they reduce the outflow venous pressure, right atrial pressure that impedes renal perfusion. Also, those therapies, ACE inhibitor and even more so ARNI, can vasodilate the afferent renal arteriole, which becomes vasoconstricted in very advanced heart failure under the very high catecholamine tone. So they may improve inflow pressure this way, particularly ARNI, via the increase in natriuretic peptide. And this is a slide from the SOLVED trial. You can see here the solid gray line. Patients who experience a rise in creatinine with enalapril had lower mortality than placebo patients who experience a rise in creatinine, or even placebo patients who did not experience a rise in creatinine. Now, if creatinine rises more than 50% or more than 0.5 mg per deciliter, the prior SOLVED study analysis suggests that even those creatinine elevations do not preclude a large mortality benefit under continued ACE inhibitor therapy, which maintains its more striking benefit in this group. However, ESC guidelines and common sense tell us that we need to make some adjustments if creatinine rises more than 50%, such as reduce other blood pressure lowering drug, as a reduction in blood pressure is frequently a driver of creatinine rise, not just ACE inhibitor per se, any reduction of blood pressure. Also ensure the patient is not using NSAIDs, assess for excessive diuresis, and consider reducing the diuretic dose or holding it for a day or so if the patient is euvolemic. Along with that, hold the ACE inhibitor for a few days only just to allow renal recovery, then restart the same or half the initial dose. Only if creatinine rises over 100% or to more than 3.5 mg per deciliter, or if GFR drops to less than 20, ACE inhibitor is stopped. And all I described is not just based on data, it's also based on that ESC heart failure guidelines supplement. And to go back to our case, this patient experienced a drop in blood pressure under therapy that is only mildly symptomatic with mild dizziness, Do not interrupt therapy for that. Expect it to get better and reassure the patient he's still able to stand, think, and urinate. So try not to change therapy, neither beta blocker nor ACE inhibitor. His creatinine rose, but less than 50%, and his BUN rose less than 50%. So try to keep therapy and keep monitoring creatinine. Now, this patient's JVP is a little high, 10, 11 centimeter. Had it been normal, I would have considered reducing the dose of furosemide and keeping the same lisinopril or carvedilol. But his JVP is a little high, so I don't want to reduce the diuretic dose. Had this patient been more severely dizzy and not able to function or get out of bed, then I would have had to hold lisinopril and carvedilol and restart potentially lower doses and sequential. Also, in those patients, consider staggering the medication. Give the lisinopril at 7 a.m., for example, and give the carvedilol at 10 a.m. Do not let both drug effects peak at the same time. Also, imagine another case scenario. If this patient's JVP was normal and he was having more severe dizziness along with a more severe rise in BUN, doubling of BUN. In this particular case, I would reduce furosemide and I would actually hold it for a day, then restart furosemide at a lower dose, and I would hold lisinopril for a few days just to allow the renal function to recover. Then I would restart it, whether the same dose or maybe half the dose. Now, everything I described regarding renal worsening with ACE/ARNI applies to heart failure with reduced EF. This is completely different in heart failure with preserved ejection fraction. While early worsening of renal function after ACE/ARB does not reduce the long-term benefit from this therapy in systolic heart failure, early worsening of renal function after ACE/ARB is associated with worsening of cardiovascular outcomes and mortality in heart failure with preserved EF. According to two studies, one a post hoc analysis from iPreserve trial and another one a post hoc analysis from the SHARM trial. And worsening renal function was defined as a creatinine rise more than 0.3 or more than 25%. And why is that different in heart failure with preserved EF? Part of the reason is the fact that ACE inhibitor, ARB, and ARNI do not reduce mortality and do not clearly reduce morbidity in heart failure with preserved EF. So here you have a therapy that does not improve outcomes in heart failure with preserved EF, so we're less likely to tolerate any creatinine rise. And the creatinine cutoff for interrupting those therapy is 25% in heart failure with preserved EF, as opposed to 100% for drug interruption in heart failure with reduced EF and 50% for drug modification in heart failure with reduced EF. Now, this is also different in the general hypertension treatment with ACE inhibitor therapy without heart failure. In this case, an increase in creatinine of up to 25 to 30% with ACE/ARB is tolerated, as these agents are beneficial for the kidney function over the long term. An acute increase more than 30% is associated with worse long-term renal outcomes compared to no acute increase. Yet, even in the latter patient, the worsening of renal function may rather be a marker of adverse renal hemodynamics rather than a harm from specific ACE inhibitor, and continued ACE inhibitor therapy seems to reduce long-term renal and cardiac event compared to no ACE inhibitor therapy. That said, it's prudent to withhold ACE inhibitor in the general hypertension population when creatinine rises more than 25 to 30%. So the cutoff in general hypertension treatment is 25 to 30%. In heart failure with preserved EF, it's 25%. And in heart failure with reduced EF, it is 100% for drug discontinuation and 50% for drug modification. Now, in the general hypertension population, the following three conditions most commonly explain a creatinine rise more than 30%. Hypovolemia, intermittent hypotension, and nephropathy with GFR dependence on the angiotensin system. So what to do if creatinine rises with ACE inhibitor over 30% in the general hypertension treatment? This does not dictate permanent interruption of ACE inhibitor, even in the general hypertension treatment. So what you do, you assess the patient for intermittent hypotension or orthostatic hypotension. A diuretic that was recently initiated may be withheld. In case of intermittent or orthostatic hypotension, ACE inhibitor is interrupted temporarily, then you monitor the blood pressure, then you attempt to restart ACE inhibitor later at a lower dose. Now, in the absence of obvious hypovolemia or recent diuretic initiation or excessive or intermittent BP drop, ACE inhibitor is generally discontinued and renal artery stenosis ruled out.